Hello, listeners. Before we begin today's episode, I want to share an important update with you. The PAOS Las Vegas On-Demand CME package is officially here. We're bringing you on-demand access to all of our 2025 annual conference lectures designed to elevate your orthopedic practice. To start us off, we're giving you a free preview with the November video of the month, Ortho-Oncology, What Not to Miss, presented by Dr. John DeVries. Dr. DeVries' lecture dives into the red flags, referral pathways, and clinical pearls every orthopedic PA should know when encountering potential oncologic cases. It's a must-watch for anyone committed to early detection and optimal patient outcomes. Whether you missed the meeting or want to revisit your favorite talks, PAOS On Demand AV delivers the full experience. Anytime, anywhere. Go to the PAOS.org Learning Center, where you can purchase discounted AV and self-assessment exams to meet your year-end CME needs. Welcome to the OrthoPAC podcast with your hosts Sam Dyer, Chuck Dowell, and Miles Gilbreth. Please join us as we attempt to fill in the gaps between education, current events, and real-world practice.
My name is Chuck Dowell. I'll be the host of the podcast today. Today we're joined by Tayleigh Talmadge, one of our scholarship winners. Specifically, her project was comparing the medial patellofemoral ligament reconstruction and the newest technique involving the medial quadriceps tendon femoral ligament reconstruction. Where did you come up with the concept with this? Were you on an orthopedic rotation?
I was, yeah. So my preceptor on my orthosurgery rotation, we did a few of these MQ-TFLRs, and it was pretty fascinating. And then watching the results for the patients that would come in post-operatively, like a year out, and just visit. They're doing so well.
Is that what you feel like you noticed, that like post-operative patients would have quicker recovery, improved recovery?
Yeah, I would say so. They also don't really go into a brace right out of surgery. That was also pretty cool because the idea is the graft placement and how it's wrapped in the VMO and attached to the distal quad is the tighter, your quad gets, the tighter the graft gets, the more secure the patella. And so they were very pleased with it, and their downtime wasn't as much as the MPFLR.
Yeah, that makes sense. I guess a question you may or may not be able to answer. I mean, with some of these surgeries, quad activation is a difficult thing. Like, could they lose the ability to kind of activate those quads? And so that would then render this not as dynamically stable. Did you ever see that end?
That's a good point. Did I ever see the No, we didn't.
Yeah.
I didn't go into depth on that. And that's a great question that I should have asked my physician.
Yeah, I mean, I just coming from like a sports and or joint perspective, I mean, we get a lot of quad attributed to poor activation when we mess with that extensor mechanism or do anything around the front of the knee. And so,
Absolutely.
as you said, the concept of the graph is that with the activation of the quad, it creates the stability. But what if the quad's not firing? You still have an issue. So
Right. And then you think about your ACL patients, and have they had an ACL tear before? And are they in a sport where they one day might need one? Because then you have to think about if they want to use a quad tendon graft. So good point.
Yeah.
I'll have to look into that. I think there's a lot more studies that need to look into it. I only found a slim selection.
Well, I think with a lot of these newer concepts, there's some studies overseas and some small studies that show success, and it requires further studies and kind of time to show if it's a long-term benefit or not. And so, but it makes sense. Conceptually, it makes sense. We know patella fractures is a huge risk with these MPFO reconstructions, and when you're putting the holes in there and kind of misplacements of those. So,
Right.
the dynamic stability definitely makes sense.
Yeah.
The in-Salsavati ratio and the patella alta and patella baja, when you went through your research, did that affect any of this? Because I feel like that would have an effect on this graph.
Totally. So I had to weed out a lot of those studies because they did talk about patella alta in particular with the MQ-TFLR. And so there are studies out there also for trochlear aplasia, is that what or dysplasia?
Dysplasia, yeah.
Yeah. And so I just saw those and I would immediately take that study out because it would have gotten way too weedy. But the results are there. they love it for those.
Yeah, I mean, it makes sense. The dynamic stability makes sense. But, if you're, we think you engage the groove, at about 30 degrees to kind of then stabilize and have the structural static stabilization. But if you're if you're too high, you're not engaging that until a little bit more. And so maybe this graph is not the best choice. Just something I thought about when I was reading your poster presentation was, hey, I wonder how much this affects, and are we taking this into consideration on, patient choice and who we're doing this on?
Yeah, because the patella alta is a known risk factor for the failure of MPFLR.
Mm-hmm.
So yeah, I need to study more biomechanics.
No, it's just, I think these are all questions that are to be answered, right? That I think with more doing this presentation or doing this procedure more on these patients, I mean, what typically happens, and probably in your practice, was, hey, we did this on these select patients that were perfect candidates and they did well. Hey, maybe this patient that's not quite a perfect candidate, are they going to do well or are they not going to do well? And that's kind of the next steps in the process of all this, for sure.
Right.
It's interesting they were embraced afterwards, though. That's definitely helpful. I assume they were weight bearing was tolerated. They were allowed to.
Yeah.
Did they use cane crutches for any certain time period?
Some did, some didn't. They felt comfortable and strong enough, and maybe it's that athlete mentality. I don't know. It's kind of that age group, like 15 to 19, and it was kind of cool to see them in their like 20, 21, 22, and they're doing well. So I'll be interested to see what more comes out of this. And I know that they're talking about, and they've done combined MPFLR and MQTR, but I'm like, is that too much? Are we overdoing it? I'm not sure.
The question is that like a revision scenario that somebody has, an MPFL and then has recurrent instability? What can we use to improve the stability and maybe the dynamic stability of the MQ? Well, I get MQTFL. Is that right? MQ.
Yep, that's right. It's a tongue.
Yeah, it's a tongue twister. Maybe that, it's kind of similar to the ACL. Somebody has a revision ACL. Do we add an ALL to it to kind of create some more rotational stability? So I think in my mind, it'd be a similar concept of revisions. This would be something you definitely look at. But
yep, they said that you can use the MQTFLR for the revision MPFLR. So
at that point, are you starting to talk about a McKay or Fulkerson's, a tibial tubercle osteotomy to improve, or are you going to deepen the trochlear groove? You start talking about those kind of structural changes as well as not just the dynamic changes. Was there any literature on the MQ-TFLR with like a Fulkerson's or tibial tubercle osteotomy? Did they ever discuss that or no?
I don't think my studies did at all, and maybe that goes into those trochlear dysplasia and patella alta cases.
Yeah, because I mean, in some of these patients, we look at their Q angles and their TF to TG angles, trochlear groove to kind of the tibial tubercle TT to TG angle. I apologize, and see if that is playing into their role of instability. And sometimes the dynamic stability is not enough. You have to make structural changes to improve. So that's probably the next iteration of kind of discussing and or researching this.
That's why the MPFLR is such a tried and true. I think it's surgeon dependent. I can't make that call. I'm a PA student. I don't know what helps them with their decision making, but I think this is just a new avenue for those select few cases that can use it and benefit.
Yeah, it's definitely exciting. Do you know the concept behind it? What was the first surgeon that kind of thought of it? Do you
Fulkerson and Edgar in 2013 were the first that described this technique. And I know that there's a few branches off of the idea that some surgeons have adopted as their own, adapted and modified for their own practice. So I went back to the foundation and who did it that particular way, because there's a lot of different methods and a lot of different descriptions of where the graft is going to be tunneled and so on and so forth. And Tanaka's articles do a really good job at describing the original technique and how they use it in their practice. So that was 2013, which is not too long ago. I had to look a little into history because I was going to use that in the talk today. Because I think in 79 is when they first described the MPFL, and they saw it as a single unit from the adductor tubercle to the superior medial aspect of the patella. And then in the 80s, or what was it? No, 93 is when they found that the fibers actually did blend into the distal quadriceps too. And then in the 2010s is when they determined that the MQTF-LR could be used.
Interesting.
Yeah.
Yeah, I know I've worked with some different sports surgeons, and some of them definitely differ in their placement of the graft on that kind of superior portion of the patella. And I've had a couple who have taken kind of one of the branches of the graft and tied it into that distal quadriceps area, conceptually thinking the same thing as this, but it was never, documented. It takes that one doctor to then write it up and say, hey, this is the technique. There's always variance among the surgeons on where that, superior graft is placed. Definitely an interesting concept. This was a literature review, is that correct? You guys didn't directly do a study?
No.
There's certain aspects of sports medicine that are evolving, and that we have a lot of patients come in with that have mediocre to poor outcomes, and patellofemoral pain and patellofemoral instability is definitely one of them. And I've been doing this for a while, and I know throughout my career there's been different evolvements as far as how we treat this. When I started, it was like every patient that came in was conservative physical therapy. Nobody got surgery right away. And now some of these patients, we're doing surgery right away because we know that they inherently will fail physical therapy. So it's definitely one of those fields, I feel like, in knee surgery and sports medicine surgery, that we need more of these evolving techniques in. And so that would be my thought process and why it was selected, because it's an interesting concept for sure.
Yeah. And to have been able to been a part of this procedure and seeing it and trying to memorize it mentally, it was a task. It was a really fun study, and I appreciate you guys having me on.
Well, yeah, we appreciate your time. Thank you for coming on. Also, don't forget to check out the CME on demand from the PAOS website from our most recent conference in Las Vegas, where you can have access to all the videos and presentations and earn your CME that way.